It's good to get started. Yeah, for the sake of time, we are very delayed. My name is Fantabil. I'm from Ethiopia. Currently, the head of Decision Science Unit at the Ethiopian Public Health Institute. I'm actually an epidemiologist by training, but I also did some postdoctoral training on policy research as well at Harvard. So in this session, we have around like 5 presentations in the areas of health workforce, innovation, and impacts of policy on workforce in general. Like we'll have 5 presentations. We're supposed to have 5 presentations, but we have only 3 presenters around. It looks like, I mean, for the sake of time, that's good. We'll manage it. And then we'll have also adequate time for Q&A at the end. So I will maybe introduce you the first presenter, who is Shengetai from South Africa. He is currently a researcher and also lecturer at the Center for Health Economics and Decision Science at the School of Public Health at the University of Witwatersrand in South Africa. So he will be doing his presentation on the association between the health promotion levy and employment in South Africa. So I call upon Shengetai to the podium to present his work. So you will have 10 minutes for the presentation. Over to you. Thank you.
And thank you for your presence. Yes, it was going to be very difficult to speak to myself. Yes, so as my name has been introduced, I am Shengetai Dare, yes, based in South Africa. So my presentation is on the association between the health promotion levy and employment. And in this study, we use an interrupted time series approach. Okay, so in terms of context, let me start off by highlighting that South Africa has got a high prevalence of overweight and obesity, to the extent that in 2016, about 67% of adult females were obese, were either obese or overweight, while 31% of adult males were also either overweight or obese, with 13% of children under the age of 5 were also either overweight or obese. And because of that, South Africa is among the highest in terms of prevalence of obesity in sub-Saharan Africa. And as a result, the economic impact of obesity and its associated comorbidities is actually high to the tune of 30 billion rands as in 2020. Now, because of that, the government had to come up with some strategies to try and disincentivize people from consuming SSBs, which is sugar-sweetened beverages. Reason being that there is overwhelming evidence that link overweight to the consumption of sugar-sweetened beverages. So in 2016, through the budget speech, the government proposed the introduction of a tax on SSBs. And in 2017, the government came up with a formal proposal in which a tax was going to be introduced and levied at 2.6 South African rands per gram. And that was equivalent to about 20% of the retail price of the most popular brand. And This formal proposal actually faced serious resistance from the industry. They were arguing that it was going to impede employment. Now, in April 2018, the tax actually came into effect. Surprisingly, because of the pushback by the industry, there was actually a massive scale down. Instead of the tax being left at 2.8 cents per gram, it was actually pegged at 2.1 cents per gram of sugar for that which is above 4 grams per 100 meals. And that was approximately about 10% of the retail price, which is far below the 20% which was initially proposed. Now, in 2019, the health promotion levy, which we also refer to as the sugar tax, was raised based on the inflation rate of 5%. So it was raised from 2.1 cents to 2.21 cents per gram. In 2022, there was also some proposals made by the government through the budget speech where they wanted to raise the tax from 2.21 cents per gram to 2.31 cents per gram. However, because of the pushback by the industry again, this was postponed. In 2023, through the government, the budget speech as well, the government actually proposed to review the health promotion levy or the sugar tax. In this case, they wanted to raise the sugar tax and also reduce the threshold of 5 grams per 100 meals, and also expand the tax to include 100% fruit juice. But again, because of the pushback by the industry, this was fiercely resisted to the extent that the government had no option but to postpone the implementation. Okay, so based on this, the aim of this study was actually to investigate the association between the health promotion levy and employment in the sugar-related industries. We hope that this knowledge is important as it will also be relevant for policymakers as they consider reviewing the text. Okay, so in this study we use quota labor force survey for the period 2009, the second quarter of 2009 to the second quarter of 2020. And this survey is actually national representatives and is household based. And the data is actually on labor market activities in all sectors of the economy. And based on the structure of the data, we classified sugar-related industries into 3 categories, which in this case is agriculture, manufacturing, wholesale, and trade and retail. Oh, sorry. Okay. This is actually the structure of our data. We are not going to dig deep into this because of our time. Now, in terms of empirical estimation, we use an interrupted time series approach, which actually the model is as depicted on the screen. So our dependent variable in this case is the number of employees for each industry in period T, which in this case is in quarters. And T in this case is the time elapsed since the start of the study. And X is a dummy variable which represents the intervention. So it takes the value of 1 for the period post the intervention and 0 for the period prior to the intervention. Tx is an direction term of time and HPL, which is time and the intervention. And P actually are the provinces, so it accounts for the fixed effects for the provinces. Okay, so in terms of the trend of the overall employment, you can actually see that When the HPL or the sugar tax was introduced in 2018, in the second quarter of 2018, that vertical dotted line, we don't see a significant change just casually by mere or naked eyes. We don't seem to see any significant change in terms of the trend of employment. And industry-specific employment levels are also as depicted here. And again, we don't seem to find significant change of the trend of employment across industries following the introduction of the HPL or the sugar tax. Now, in terms of the regression results, we actually use the ordinary least squares model as our main, and also try to, for the purposes of robustness checks, employed two other approaches, which is the general least squares and the random effects models. And I've actually highlighted two key explanatory variables in this case, which are boxed in red. And based on that, we can actually see that there's no statistical significance in terms of the association between HPL and employment. In this case, if you are to look at HPL alone, which depicts in this case, which actually indicates the effect of HPL as and when it was introduced. While the HPL time interaction term there actually shows the effect of HPL over time. And across those two key explanatory variables, we actually see that there's no significant, there's no statistical significance between the HPL and employment, which is contrary to the claims by the industry. Okay, so based on our results, we do argue that one, we don't see any association between employment and the HPL. And again, our results are actually comparing favorably with those around the world. And there are actually at least 4 reasons that explains why we found no statistical significance between the sugar tax and employment. One of the reasons is that say for instance, we've got those firms which are into the production of multiple products. You realize that such firms may internally reallocate their labor force to products that are unaffected by the HPL, and at the end of the day, there will be no need for any employment adjustments. The second reason is that we have found strong evidence of reformulation following the introduction of the HPL in South Africa. And as such, you realize that most companies that are into SSB production have actually substituted sugar with sweeteners, to the extent that the taste or preference, the taste of the products remain the same, and the preference of the customers also are unaffected. So at the end of the day, there's also no need to reduce employment or readjust their employment levels. The third being that in the event, if the demand for the affected products is actually not affected or is affected slightly, then following the implementation of the HPL, then obviously the industry will find no reason to adjust their employment levels. The last but not the least is that consumers may substitute untaxed products with taxed products. And this actually will be from the same companies. And at the end of the day, there's no need to adjust employment levels. Having said that, we actually have two key recommendations. The first one is that the government should consider raising the HPL to at least 20% as recommended by the WHO. The second recommendation is that the government should also consider expanding the HPL to produce, contrary to their claims that the HPL will actually reduce employment. And in so doing, we actually did another study and found that the HPL, if it is expanded to fruit juice, it will actually reduce the consumption of SSBs and also enable the government to raise additional revenue for the fiscus. Having said that, I thank you. By the way, this study has recently been published. So that is the link that you can actually access for full details. And this is my contacts. Thank you.
Thank you, Dr. Shangatai, for your very informative and presentation, and also very important findings. I think that is something probably need to be considered in other countries as well, as the burden of obesity, overweight across all age groups of the population is increasing. Thank you. So I will move to the next presentation. So our next presenter will be Dr. Rim. Dr. Rim is health economist and researcher at the Institute for Research and Information in Health Economics, which is based in Paris. So Dr. Rim will be presenting us their study on clinical competence of private and public primary healthcare providers in Tunisia. So Dr. Rim, this is your turn. You have 10 minutes. Thank you.
So thank you very much. So I would like to start by sharing this graph. This graph is about the disease burden, the global disease burden in 2018. This is the same graph adding one other disease, which is poor quality of care. We can see that these are two studies actually that attempted to quantify the impact, the mortality that poor quality of care creates. And we can see that it's huge. And other vast evidence, especially in low and middle income countries, have been showing the same bad results, I would say. Specifically in terms of under provision of needed care or under diagnosis of serious diseases. So there is a widespread consensus now that poor quality of care is a major global issue. Public and private provision of care is a key determinant in knowing what's going on in the private and public provision of care, is a key determinant of knowing what's the mix of quality care can be provided in a given country. There is a heated debate about whether the private or the public sector is performing better, and a vast literature as well. The reality is that this literature is weak and the underlying body actually is weak. This is the main reason. So what we know is that there are difficulties because providers are, the studies which tried to compare the private and public sector did not focus on the same providers. Providers are heterogeneous. We know that there are formal, informal, registered, unregistered. And this is a problem for comparison. Another problem is comparing diseases or patients that are different. So what we call the patient mix, patient case mix. These difficulties are illustrated in this slide. So we can see here, these are two big systematic reviews in the same journal, same year, 2011, and both came up with conflicting conclusions. One says private is better, the other says public is better. So this presentation is about, we'll try to overcome some of the difficulties of this literature. It's entitled Clinical Competence of Public and Private Primary Care Providers in Tunisia. And I wrote it with my co-authors, Mylène Lagarde from LSE and Timothy Powell Jackson from the LSHTM. So, Tunisia. Tunisia has known significant health improvements in the recent decades. And this is due mainly to its primary healthcare system, where the GPs are the cornerstones of it. I said earlier that we are going to overcome some of the difficulties. One of them is that GPs in Tunisia are the same, meaning they had the same medical education. Medical education is regulated in Tunisia very much. There are only 4 medical schools, and they all provide theoretically the same education. So, despite this expanded access, nothing is known actually about what these providers know about their competence. And GPs in Tunisia can be practicing in the private or the public sector, knowing that the public sector is the historically the largest. It has an extensive network of health facilities, and the private sector grew very much and is very dynamic, with half of GPs working in it. So the objectives of this study is to explore the GP's characteristics in the public and private sector. It's to compare, secondly, the competence of GPs in both sectors, and to identify the determinants of competence. A little bit about the methods. So the study is observational, cross-sectional. It was done between November, data was collected between November 2017 and January 2018 in urban Tunisia, in the region of Grand Tunis, which includes the capital Tunis and 3 other governorates. We randomly selected a sample of public health facilities and private clinics, which are solo practices, and obtained data from 177 public GPs and 79 private GPs. So, to explore GP characteristics, we used individual structured GP surveys to measure the socio-demographic and other practice details about the GPs. And we use descriptive statistics and statistical tests to compare both groups. For the second objective, which is to compare competence, we use clinical vignettes. So after administering the surveys to each GP, we administer a set of clinical vignettes. A clinical vignette is a standardized hypothetical case study that describes briefly a case, gives details about the patient history, and after that, in our vignette at least, we ask questions. We asked here specifically 2 questions, one about the suspected diagnosis and one about the actions that the GP would do to manage the case. So I said earlier that, again, one other difficulty that we overcome with this study is that the fact that we standardize the clinical vignette means that the patient case mix is controlled for. We account for it. So we control what's comparable. We compare what's comparable. And in our study, we use 5 different vignettes related to 5 common diseases in the primary seen in the primary care in Tunisia, which are TB, asthma, depression, bronchitis, and I said TB, asthma, bronchitis, depression, and the 5th will come. So finally, to identify the determinants, we link the vignettes to the surveys, and we use the approach of multivariate logistic regressions to see the associations between the competence measures, correct diagnosis, correct management, and the GP characteristics. Moving on to the results. So we see here the GP characteristics. So most of the GPs are female in our sample, and they're predominantly so in the public sector. They're middle-aged, and we see that in the private sector, the age distribution is more even than in public sector. We can see that the experience in the other sector, having had 5 years of experience in the other sector, was significant in terms of difference. So the private GPs who had 5 years of experience in the public sector were more important. We can see that the GPs who graduated from Tunis Medical School compared to the other 3 schools are those who are predominant in our sample, with the public GPs being more so. And in terms of continuing training, we can also see that the difference is important between public and private as well. The second objective, which is to compare competence. So across all cases, we look at the measures of competence, and we see that GPs were nearly able to manage correctly the vignettes in 70% of the cases, with the public GPs being more likely to do so. With a more stringent measure of correct case management conditional on correct diagnosis, we see that the rate fell down to 50% only, with the private GPs being less likely to do so. Looking at different cases, so it was in China, the 5th. So looking at the different cases here, we see a wide variation. With TB and angina being performed, where the GPs performed better in TB and angina. And for depression and asthma, we see a low correct case management rate of 55%. So looking at the associations between competence measures, here it's correct case management. This is an aggregate estimate across cases. we have a first set of controls here in the first model, and the result confirms what we have seen with the descriptive statistics earlier, and we see that private GPs are less likely to perform correctly the vignettes. Adding a second set of controls, we see that having graduated from Tunis Medical School specifically versus the other school is a key determinant of quality of care competence. And here, what's interesting is that the being private is not anymore a significant aspect. So a quick wrap up. So about the finding, we find that in the study that there is a moderate overall competence with significant disease-specific gaps. Public GPs outperformed private ones, which is challenging the popular perceptions in low and middle income countries. And the place of initial education was a key determinant of competence. To conclude, the studies opened the black box of primary care quality in Tunisia, which was unknown. We had only some anecdotal evidence about it. If anything, it did that. It highlighted the importance of competence as a dimension of quality of care. And this points to the need to improve primary care quality, particularly with NCDs, non-communicable diseases, and across both providers through enhancing medical education. A few policy recommendations, updating medical curricular, and in a consistent way across medical schools, because we saw that the Tunis Medical School was standing out. Monitoring both public and private care quality. And of course, further research is needed because we don't know what's being done in practice, actually. Although private GPs are underperforming compared to public GPs, we don't know whether the private GPs would be more motivated, would exert more efforts in practice with patients. This can play a role in increasing quality of care in practice. Thank you very much.
Thank you, Dr. Rim, for the very insightful presentation on your work in the competency of doctors in Tunisia. Yeah, I mean, considering the absence of two presenters, actually, we have been flexible and giving you some more minutes. Thank you. So maybe it's better to move to the next presenter. So our next presenter will be Dr. Peternella. Dr. Peternella is a research fellow at the Royal College of Surgeons in Ireland. And currently she is also the principal investigator of Sierra Leone's unsalaried health workforce. So Dr. Peternella will be presenting their study on the situational analysis of health, human resource for health at primary healthcare facilities in Nigeria. So I call Dr. Peternella to the stage. You have 10 minutes for the presentation. Thank you.
Thank you. Thank you very much. Just trying to time myself. Thanks very much for the introduction. That was all correct, except for the study is in Sierra Leone, which says here. But yeah, I hope you can bear with me. the clicker here. Okay, so yes, as the title says, the study is looking at unsalaried health, the unsalaried health workforce, which is still a cornerstone for of Sierra Leone's public health system, despite the fact that policy commitments to change and to stop the over reliance of on unsalaried health workers. This study was conducted with Federico Saracini, who is a PhD student who works on the project with me, and Dr. Dincy Williams, who's a fantastic Sierra Leone a researcher who collected some data that I'll be presenting here. Sorry. No. Which one do I click? Oh, is it this one? I'll just nod at you. Okay, great. Yeah, that's perfect. Okay, so just a brief note on the prevalence of unsalaried health workers in Sierra Leone. The country relies on unsalaried health workers, and between 1/3 and a half of all clinical health workers work on an unsalaried basis. The graph over there is a screenshot from a report that came out in 2016. It's the first time that a proper study was conducted, an audit of health workforce in Sierra Leone, which basically noted that Sierra Leone at the time had about 9,000 health workers on the payroll. Sierra Leone is a small country, only now around 8 million citizens. And it noted that there's an equal number of volunteers, as in unsalaried health workers also working in the system. And what you can see on this graph is that while of those unsalaried workers, about 45% was kind of support staff, so non-clinical staff, 55% was clinical staff. So that's quite a significant number. So I'm the PI of a 4-year study that looks at not only at how many unsalaried health workers are there in Sierra Leone right now, but what is the impact of relying to such a large extent on an unsalaried health workforce. We found that the pervasive use of payroll inclusion deferral continues. So the idea that graduates from nursing schools are provided, are basically deployed in the health system, but they are not, basically they're told that there is no space on the payroll, therefore their inclusion on the payroll is deferred, and eventually they'll have to apply and will be added to the payroll if they're lucky. And in the meantime, they kind of have to make do in order to survive financially. The next one. Sorry, can I try? Okay, yeah. So the current research, as I already said, is kind of looking at the impact of those health researchers, those unsalaried health workers, and trying to figure out what the research can really say about the link between their presence within the system and health outcomes. And we started by looking at what is already known about the consequences of having so many unsalaried health workers in the system. So there's a QR code of a paper that we published, which is looking at all of the references in the literature regarding the unsalaried health workforce. So very often in the literature on the primary care in Sierra Leone, there's mentions of these volunteers and mentions of the volunteers in all sorts of different contexts. And a lot of that's kind of negative connotations, not having enough volunteers to have a full load of operations in an operating theatre in a hospital, because there aren't enough nurses available for post-operative care, etc. So that was the basis of our study, just looking at what evidence is already out there, and then we went to try and collect data, figuring out what are the impacts that we could find. Okay, I won't bore you with all the details here, but this was more or less Our methods, we did a lot of qualitative data collection. I spoke to about 110 salaried and unsalaried health workers and discussed workloads, and discussed how people got by, how people coped with their current situation, both those salaried and unsalaried, because also salaried health workers are not paid very well. My colleague who is doing his PhD looked at the community side of things. I'll not be reporting on that, but we will be publishing on that later. And then I also looked at health worker training colleges, at health worker students, and Ministry of Health staff were interviewed throughout the country. And we also spoke to a lot of other key informants and stakeholders in the donor community, NGOs, etc. And then we had a bit of quantitative data collection, which actually was something that we hadn't anticipated doing, but we realized that at national level, the government was unable to tell us anything about how many unsalaried health workers were operational in their system. So we ended up then collecting data, focusing only on primary care across the country, because we were unable to also collect all that data at hospital level. So we collected staffing data. We approached all 16 districts in Sierra Leone. 10 of those districts returned their data to us. So we have pretty good granular data on the staffing in 10 different districts in the country. We also collected data on enrollment in health training facilities. Again, I'll talk about that in another presentation later this afternoon. So this was the data that we were able to collect. So basically, for all of the different districts, we looked at how many community health officers, community health assistants there were, how many midwives, how many state-registered nurses, and state-enrolled community health nurses, maternal child health aides, nursing aides, laboratory technicians, and others were working. And for both those, or for all of those cadres, we asked the district to give us the numbers on how many were salaried and how many were unsalaried. What we found is that there are slightly more unsalaried health workers working in the at district level, or at at primary healthcare level, which was actually quite shocking, because if you remember back to the very first slide in 2016, there was there was a much smaller amount of clinical health workers that actually worked on an unsalaried basis. Here we find that there's more health workers who work at clinical level in primary healthcare. Those 10 districts that reported data to us make up a total of 55% of the total population. So and it's a mix of kind of more urban and more rural locations. So we can safely say that if we extrapolate it across the whole country, there's definitely more unsalaried clinical staff than salaried clinical staff, which is really quite shocking. Okay. So what did we find from the qualitative data? And what we found is that both salaried and unsalaried staff appear to adopt the same coping strategies, which include informal charging, selling medicine that they purchase privately to patients. So they are creating a higher cost for patients who, some of whom are entitled to free care, which generally they're not getting. For the unsalaried health workers, we saw a much greater engagement with sort of additional types of jobs that they also held on the side. A lot of kind of hustles, a lot of small jobs. A lot of health workers were engaging in selling things at clinic level, things in the market, selling things to their colleagues, maybe cooking dinner and then selling, or cooking lunch and selling that to staff, to other staff, selling water, selling phone top-up, selling kind of rice by the cup, selling so many different things. So very, very tiny margins. When I ask people to kind of calculate how much profit they make from some of those jobs, it's absolutely minute. So you can see this is real evidence that there's real hardship in you know, among those unsalaried health workers. And these kind of jobs were much more prevalent among those who worked without a salary. And then there was definitely a lot of soliciting of payments from patients, but this was often described as patients giving them a gift, or patients being kind, or if patients are nice, or if patients remember us, or if patients give us a recognition or an incentive. So, but very often what we found is that, you know, from the interviews my colleague did, is that you were basically being asked to give that incentive as a patient. It's not that you voluntarily hand over your money. People find it very, very hard to pay for treatment. So, but again, patients or the unsalaried health workers also have to survive. We also found that some health workers admitted to treating their neighbors and private patients. So that is also part of their coping strategies. So our overall study basically pointed to a number of key unintended consequences. As I already said, the charging is a clear barrier to access to care. From the community-based evidence, people really struggled to pay for the care, and people were very aware of the fact that they shouldn't pay for certain care. Sierra Leone has a free healthcare policy for children under 5, for pregnant women, for lactating mothers, and more post-Ebola, they've also added some additional groups that are also entitled to free care, like recovered Ebola patients, people with disabilities. None of them are receiving free care. And it's not only an issue at primary care level. You also see that kind of looking at the literature and speaking to other people who work in maternal health and work at hospital level. There's a great reluctance to be referred to hospitals because the care there is more expensive again, or there's more payments to be made to a range of different people who treat patients at hospital level. So there's a great reluctance to be referred for example, obstructed labor, which then is obviously one of the delays that eventually could lead to maternal mortality and also to neonatal death. And those are very, very high. Sierra Leone still has very, very high rates of neonatal mortality and maternal mortality. So overall, so one of the things that is kind of that shows how significant this is that the DHS of 2019 cited that a lot of patients, 67% said that it's a real problem getting money for treatment. The second one, we also found that lots and lots of health workers are selling medicines that they've bought privately. It's not obviously their fault that the government is providing very little in terms of commodities for primary health care. But what you find is that this has become a bit of a gap in the market that health workers are filling. So health workers are buying medication and then selling it to patients, again in a markup, again adding to the cost of what should be either free care or much lower, lower cost care than is currently being rendered. And this is a handbag, a picture of a handbag that I took while I was interviewing different people. A nurse had gone to attend to something, and I just spotted this handbag at the bottom of a nurse's chair. This, I think, is really telling. It wasn't the only place where I came across this. This is part of what people do to survive. The third thing, and that's kind of less, I'm coming to the end, is less commonly thought of. We see that the high prevalence of unsalaried health workers is creating an opportunity for those who are salaried specifically to be absent from health facilities more regularly. So this is a picture of a roster I took that was hanging up in a clinic, and you can see that a whole series of health workers in the labor ward are scheduling themselves off work every other week. And they can do that because there is quite a range of staff, and also because they have clearly decided that patients don't need a range of health workers. They don't need a full quorum of health workers at the facility. Instead, they give themselves a week off, and in that week they can go and engage in private practice. And so again, the presence of these unsalaried health workers is providing an opportunity for absenteeism. And what you find is that unsalaried health workers are left in health facilities to do the night shifts, to do the weekends, to provide a lot of the care that they sometimes are not qualified for, because the higher qualified salaried staff are absenting themselves from the clinics for longer periods of time, sometimes days on end. So I think this is kind of a bit of a vicious circle that you can see. Salaried and unsalaried staff charge for free care to generate the incentives to make sure that the unsalaried health workers can afford to stay at the clinics. What you then see is that the unsalaried health workers stay at the facilities and allowing the paid workers to absent themselves, to go elsewhere. And then you see also that the absence of medicine is creating a gap in the market, so health workers can sell medications for profit. But again, that can only work if there are enough health workers in the facility in order to attract patients to actually come to the facility to receive care. So all of these issues are kind of related, and it is like a vicious circle. So because one thing happens, then something else is made possible, and it kind of is a vicious circle that at the end, basically results in poor health outcomes. So basically, it kind of leads us to question, in Sierra Leone, we would like to understand more about what's happening at hospital level. There are many other countries where these volunteer health workers also exist, and it'd be really, really interesting to look more closely at what happens in other countries. Are similar sort of patterns being repeated? And how can countries develop a route out of this unhealthy habit of relying on labor exploitation, and where the dependence of, there's many countries where the dependence on unsalaried health workers is very significant. And we've seen this in terms of this paradoxical surplus of health workers, unsalaried health workers. So we wonder how that all hangs together. Thank you. Just acknowledgement.
Thank you, Dr. Peternella. I was very amazed. I mean, I know like in many countries, under-salaried health workforce that can be common, but this is actually my first time to hear about unsalaried health workforce. Like at the beginning, I thought you were presenting on the voluntary health workers, but this is my first time. So yeah, I'm just like very interested to learn more about this work actually. Yeah, but for the sake of time, actually, we started late, maybe by 30 to 40 minutes, so we can sneak some time from the next session. Maybe to give you a brief summary of the presentations, the three presentations we had. Dr. Chengentai, he presented us on the taxation or the health promotion levy as an effort to reduce the burden of high obesity and overweight in South Africa, and then the impacts of this taxation on the job cuts in the industry. And then our next presentation was on the competence of general practitioners in Tunisia by comparing doctors in the private and public sector. And then, so I don't need to summarize the last presentation, which is the recent memory. So we'll have maybe 15 minutes for question and answer. So I call all the three presenters to the front seat, and then probably we can entertain some questions. It depends, the number of questions allowed for each will depend on the number of hands raised. Okay. So it's the time to collect questions from the audience. Any more? 3. Yeah. Okay, 4, 5. So 5 questions. Probably, maybe I will just like make one question for every of you. Yeah, just like one question for 2 questions. Okay, we can tolerate 2, but make it brief. Thank you for the sake of time.
Thank you for your presentations. I had 2 questions, one for the lady who was presented on Tunisia, and one for Petronella. With regards to Tunisia, just to clarify, is the driving issue here that potentially better qualified physicians are being drawn to public sector health facilities due to labor protections, or is it salary? Do you know exactly what it is that is driving them to the public sector? And it's similarly with regards to medical education. One question for you, Petronella, is whether or not you knew with regards to how many of these unsalaried workers have private medical education, privately come from private medical schools or private nursing facilities for their training, or if that's a thing in Sierra Leone, and then if they had to take on debt or any sort of any sort of payment in order to finance their education beforehand.
Good morning, ladies and gentlemen. My name is Kiton Jinadu. I have 2 questions actually. One from the presentation from Tunisia. I just wanted to know, in addition to the issues that the previous speaker had raised, I wanted to know if there were other factors that you think could have been associated with some of the variations that you found in your research. And also, I have a question for the speaker on the unsalaried workers in Sierra Leone. I wanted to ask if you checked if maybe there were government policies that transitioned some of these unsalaried workers to salaried workers over time, and if there were other incentives other than the local arrangements within the health facilities that kept the significant amount of unsalaried workers continuing to provide services despite that, I'd say, unpalatable work environment. Thank you.
One here in front.
Yeah, thank you so much. I'm Olivier Andre from KIT in Amsterdam. A question for Petronella. Thank you for the presentation. It was really interesting. I think in the case of Sierra Leone, it's so interesting to see also that, the government is, at least at the district level, actually aware of the issue, right? You present that they actually have data on the number of health workers that are unsalaried. But surely they're also actually aware of some of the conditions that it does. How have you had any experiences like relaying back this information to those stakeholders, and how do they justify this? How do they talk about this? Yeah, thanks.
Okay, at the middle.
Thank you to all our presenters. 2 very quick questions. Sierra Leone, did you have an inkling on how long people stay unsalaried? And whether they just continue or some of them leave? The second part is, you say that the central level, they didn't have information. Does it mean this is a local primary level arrangement for the volunteers, or is it at national level? I mean, how do people get into employment? And then for South Africa, did we have a baseline? What was happening before the levy was introduced? Do we have trends of employment before and then when the levy was introduced? Thank you.
Okay, the last one, behind yourself.
Yes, I have a question. I'm Estelle Doshi from the University of Cape Town, the Department of Economics. And I have a question for Shangetai on his presentation on the impact of the health promotion levy in South Africa. So I really appreciated the history of the levy, because as I am relatively new in South Africa, and I knew that there was a health levy, health promotion levy. I suppose that levy is dedicated to be spent on diseases related to sugar-sweetened beverages. That's one of my questions. What's the goal? Why is it called a levy rather than an excise tax? My expectation is that it's earmarked to something. So do you have any information on that? My second question was about the fact that you don't find any impact of all of these events you have on the right-hand side. And by event, I mean the new policy proposal or the actual change in the law on employment. But I was wondering, one of your explanations for the lack of effect is that, you know, there might be product substitution within industries. So or product substitution, either product substitution by consumers who substitute from tax products to non-tax products, or from some sugar-sweetened beverages to lower sugared beverages. Anyway, and then you also explain it with other aspects of the industry, or more on the supply side. My question is whether you could actually disintegrate these. Those are just suggestions that you make, but do you have a way to actually test what's going on, what happens in effect? Is it product substitution by consumers, or is it reformulations by the industry trying to avoid taxation? That would be really informative to know. My second, related to that question, I was wondering if you have thought of using the same methodology, but instead of employment on the left-hand side, use directly sales of different types of products. I know that those data exist. They are provided by Euromonitor International, which has lots of information on annual sales, maybe not monthly sales or quarterly sales, but at least annual sales for a long list of sugar-sweetened beverages. So this would be another research question that would provide additional information to your story and enable you to have a better message in the end than just saying this is possible without really knowing what's happening.
Thank you for all the great questions. Now this is a turn for the presenters to respond to each question. So maybe depending on their seating order from my side. So let me, fortunately, everyone of you have questions. So let me start from Dr. Rim.
Okay, I think I had two questions, right? One about what makes the GPs attracted to the public sector, and the other one was about the factors associated with competence. So I'm not sure I said that GPs are attracted to the public sector, but of course, I mean, because of the time constraint, I could not develop more about the background, the context of Tunisia. The thing is that in Tunisia, to become a GP, it's the same path for everybody, for every doctor, and they self-selected. They select themselves then into the public sector or the private sector. So there is no, it's a choice from the GP. Private GPs are salaried, like in most of the health systems. In the private sector, they're paid by fee for service. And they, of course, pay the rent of their clinics, etc. They have charges. I'm not sure GPs are more attracted to the private sector. I think that it depends on their individual personal characteristics, whether they like to be, they're more independent and risk takers or risk averse. So whether they want to have a secure job or not. So this is what makes them probably, although research on that is not clear, is not there yet. But what we know is that probably public GPs are maybe more organized in terms of continuing trainings, in terms of having, you know, updated trainings, which is organized in the public sector. It's open to the private GPs, but it's not mandatory. It's not mandatory even to public GPs, but in the public sector, maybe peer pressure is more present than in the private sector. I hope that this answers a little bit your question. The second one is about the factors, the other factors. I think that what we found actually in our studies, at least in our study, gender, age, experience have no impact. There is no correlation between competence and these factors. What we suspect is that it's likely that continuing training is correlated, but in our study, the data what we extracted cannot tell us that. But we have the intuition that if we can capture a better, because we asked here, the variable says that, did you have any kind of training in the last 5 years, whether it's certified, not certified. So this is like a noisy type of variable. Maybe if we could ask a better question, that we would have a correlation between training and competence. It's not easy. We tried to do it actually, but because the level of continuing training is so low, and in terms of attendance, and we know from anecdotal evidence that the quality of the continuing training is very variable. So it's not easy to capture this. It's because this continuing training is not mandatory at all in the country. And we suspect that this is an issue that affect the quality or the competence, at least here, of the GPs. Thank you.
Thank you for your questions. Let me start off with the first question regarding the baseline. So in this case, we use a single interrupted time series approach, which makes the period prior to the intervention the base or the reference period. So in this case, we do know that the interrupted time series, the intervention 2 is a binary in this case. So we take the value of 1 for the period post the intervention was introduced, and 0 prior. So that period which it takes 0 is actually the reference. So it is self-control itself. So the period before the intervention is actually the control period. Okay. I am not sure if I got the first part of the second question, but I'll try based on how I took it. I heard like you spoke about the earmarking. Okay, so the revenue collected from this tax, the SSB tax or the health promotion levy, is not earmarked. It is also part of the general funds, which actually will be used according to the wishes and designs of the central government. So it's not earmarked. Now, going to the recommendation that we actually, before the recommendation, the suggestions, which are actually the reasons behind our findings, it's true that it was going to be more informative if we were able to dissect our products or factor in the type of products into the model. But in this case, it is not possible, reason being the structure of the data set. Because in this case, we use the labor quota survey data, which actually does not account for the products. But in this case, the focus was basically on the level of employment, because that was the pushback by the industry. So we wanted actually to understand to what extent has employment been affected following the introduction of the health promotion levy. So the data could not take us that far, but again, it was actually going to be addressing a different objective in this case. And even if we were to go for the Euromonitor dataset, the challenge in this case is that the Euromonitor dataset doesn't allow for us to conduct an employment study. In this case, it do provides for levels of sales, but again, even if we are to look into how the HPL has affected the level of sales, that again was not going to explain as to why, say for instance, we get the same results where we don't find a statistical significance between employment and the health promotion levy. That it was not going to address that as well. But I think it's a good point to say that there's room to actually conduct another study, to see how the HPL actually impacted on sales. And that is going to be actually even more insightful. And again, I think we have conducted some other studies related to what you have just raised, where we found that there is evidence of reformulation following the introduction of the HPL, the health promotion levy. We have found evidence that the industry has actually reduced the amount of sugar tax and the amount of sugar content, and replaced that with non-nutritive sweeteners, so as to avoid the HPL. And at the end of the day, with that approach, the health promotion levy actually had no effect on consumption in terms of preferences, because the sweeteners actually serve the same purpose as sugar. And at the end of the day, it is actually one of the reasons that explains why we don't have any significant change in employment following the HPL introduction. Thank you.
Thank you. Dr. Pitternellas, this is your turn.
Yeah, okay. I have 5 questions, but I'll try and be quick. So the first question was around private education and the debt that health workers take on, the unsalaried health workers specifically, who may be under pressure to to kind of make up for the money they invested. I've found that all courses cost money, except for the courses that a course called the Maternal Child Health Aid course, which is no longer available. So in the early days, there was a subsidized course, but because of the overproduction and the fact that this is an auxiliary level course, that's now been stopped. But what's interesting is that the private training facilities are sometimes cheaper than the 2 universities that also provide health worker training courses, just because some of them are really just recently established, very cheaply run, and they're able to kind of provide cheap courses. They don't always meet all of the requirements, even though they're accredited, for example, not having mannequins, etc. So that actually is a bit of an issue as well. The second question was on government policy around unsalaried health workers. I meant to say a bit more about that. So in 2017, the Human Resources for Health policy was the first Human Resource for Health policy was published, which actually committed action on unsalaried health workers with the idea that all of those who are clinical, can be verified as clinical health workers should be added to the payroll, and those who are not should be removed from health facilities. But actually nothing has been done in this regard. More health workers have been recruited, so the health workforce has expanded, but as you could see, the number of unsalaried health workers also expanded. So the system has continued to absorb new unsalaried health workers, new graduates, and made them unsalaried health workers, whereas some of the unsalaried health workers received PIN codes and became on the payroll, but not all of them. So the policy has not been followed through. And in fact, sort of more recent policies that were published in 2021, 2022, pretty much just copy and paste the same statement. Half of all health workers is unsalaried. And so nothing really has been actioned at policy level, unfortunately. The very interesting question around the district level awareness and the reaction to the idea of unsalaried health workers. At district level, they're very well aware of the problem and of the challenges. And I actually spoke to one human resource officer at district level who did not want to be named, of course, who said, well, you know, we're not supposed to allow unsalaried health workers to sell medication, but I tell them, go ahead, buy the medication, sell it, you need to survive. That's the only way we can keep them. So they are very well aware of it, and it's their kind of coping strategy. They wouldn't have half the health workers in the district if they didn't kind of use this workaround and have all these unsalaried health workers, but obviously it's at a cost. And other individuals at district level also told me, well, you know, they're going to have to eat. So if you find the things that you have found, you know, we can understand. Basically, that's kind of the tacit acceptance that this type of coping strategies is very widespread. What's also interesting is that at district level, their technical district level staff in the health sector is also unsalaried. I found an accountant who had been working for 3 years without any salary whatsoever at district level. So it's pervasive absolutely everywhere. The question that brings me to the question of how long do health workers stay unsalaried? I found health workers who had been waiting for their PIN code for 6 years, for 7 years, for a very, very long period of time. I also found people in the private sector who had worked unsalaried for 3, 4, 5 years and got sick of it and left. I asked every single unsalaried health worker what their plan was. Were they going to stay? How long were they going to stay? A lot of unsalaried health workers obviously had great ambition to become salaried health workers. They filled out the public sector application form time and time again. They were very active in trying to get themselves on the payroll. Quite a few said, I'm going to try and upskill and do more training with the hope of becoming more likely to get on the payroll. And others did say that they had a plan to actually leave if they wouldn't get on the payroll within a year, 2 years, etc. So it really, really varied. But there were people who were waiting for as much as 7, 8 years who were working unsalaried for all that time. And then at central
sorry,
level,
Dr. Petronella, just like get some, pressure from the moderators. Yeah, I mean, I know we started late by 30 minutes, and now we have compensated that by taking 30 minutes from the next session. So, yeah,
Okay.
probably we can
Perfect.
continue the discussions after.
if you want
this
to know
one.
more, you can come and
Yeah,
see me.
thank you very much for the presenters for your very insightful presentations and answers for the very insightful questions coming from the participants. Thank you. So our session is over. Thank you for your very attentive participation, for the great presentations. But still we have time to continue discussions in the tea breaks and any other time possible. Thank you, everyone. Thank you.
So the next session, is on integrated patient care. And I want to know if the following presenters are here. Elvis Omondi, are you here? Okay. Pamela, you're here too. Troshakma Pama. Troshakuma Pama. Emily Macaria. Emily, are you? Emilia is a lady. Oh. Are you switching? Okay. Kezia, Na? Yeah, oh, it's true, yeah. Okay, so we have 4. Fortunately or unfortunately, we have only 2 bios. And so within the next 90 minutes, hopefully, we're going to go through issues around patients' care and how it affects both the health economics ecosystem and the health systems itself. So the topics they are going to be talking about, the first presenter, Elvis, will try to conceptualize an individual patient simulation model to evaluate the economic impacts of integrated care for cardiometabolic multimorbidity in Kenya. So that's job-breaking title. Don't worry. Yeah. So I hope the presentation will not also be brain-breaking, you know. The second presenter, Pamela Ubozo, will be rethinking accountability mechanisms as a means of strengthening governance in primary healthcare centers in Nigeria. And then, well, the third presenter is not here, Pama. Then, so what's your name? You that is representing Emily. Sorry? Okay. So you'll be talking on the implementation cost analysis of a COVID-19 test and treat program, real-world evidence in Ghana, Malawi, and Zambia. And finally, Kezia Na, we have, yeah. Kezia Na, you will be talking about factors influencing access, quality, and utilization of PHC for patients living with hypertension in West Africa, a scoping review. Are you part of the Stop NCD? Yeah. I now remember. I've been thinking, where did I meet you? It was where we were trying to stop NCD. Okay, so we'll call Elvis. Elvis, so you're the rapporteur. Where's my rapporteur? Okay. So Elvis is a trained epidemiologist, health economist, and decision modeler with interest in the application of decision modeling to inform the implementation of effective, scalable, and sustainable interventions for health system strengthening in the prevention and management of chronic diseases in low and middle income countries. He has a PhD in health economics. Oh, it's the same thing, you already have it. He said he's doing a PhD, but I have said he has it already. But it's a PhD in health economics and decision science at the University of Sheffield. So over to you. You have 10 minutes to present. And I employ all listeners to please just note your questions at the end. We now interact with the presenters, okay? So over to you.
Thank you very much, Prof. Yeah, thank you very much. And good afternoon, everybody. I'm Elvis Wambia from the University of Sheffield, and I will present on conceptualizing an individual patient simulation model to evaluate integrated care in Kenya. Next slide. Next slide. Yeah, so by means of introduction, integrated care is becoming a very common word, especially in the research discourse in low and middle income countries, and it has been shown to be effective in improving health, managing multiple diseases. And it holds promise, especially in low and middle income countries where we are seeing an epidemiological shift, non-communicable diseases are rising. And this was one of the motivations of me doing a modeling study of the cost effectiveness of integrated care in Kenya. And to do this, I will build an individual patient model, but then what we see, especially in models in low and middle income countries, is that they rarely report the conceptual modeling process. So to build a decision analytic model, which is my main aim, you need to actually undergo a conceptual modeling process to ensure that the model is credible and valid, as well as transparent for the decision makers for which you are targeting the impact. So, next slide. So my main objective was to describe the process of conceptual modeling that I went through in the development of the economic model for this study. And I'm just here showing you the case study that I'm using. So it was an integrated care model in Kenya, which was implemented for about 4 years. And it's aimed to improve care for people with chronic diseases, including hypertension, diabetes, and cancers, and includes different activities at primary care. Key aspects include case finding and referral, as well as strengthening, drug availability in the facilities at primary care, and also strengthening communication and data in the facilities. So I used an existing validated framework by Dr. Squires and colleagues from the University of Sheffield. And this framework actually has 4 key steps in the conceptual modeling process. So aligning the framework to the decision-making process, identifying key stakeholders, understanding the problem, justifying the choice of the model that you're going to use, and understanding and incorporating the evidence for the modeling. I'll start by the first one, which is aligning the framework to the decision-making process. So it seems like the slides were distorted. So stakeholder engagement is a very key aspect of building a model. And in my study, I involved stakeholders from the beginning to where it is now, and we engage stakeholders using meetings, interviews, key informant interviews with key stakeholders, including people from government, academia, collaborators in the case study project. And we also did workshops. And the framework posits that you need to identify the kind of stakeholders that you're going to engage when you're doing your modeling or undertaking this process. So there are customers, the people who the model, your work is going to influence. There's the actors, which include like healthcare workers in those facilities, and then the system level system owners who are decision makers in that sense. So the second step was understanding the problem. And in understanding the problem, I needed to understand the activities that are involved in the integrated care model, because this integrated care model integrates hypertension and diabetes care at primary care level, which is the lowest level of the health system. And I needed to know the resource pathways that are constituted therein, identify outcomes, how they will be impacted, and also service delivery pathways. So as you can see here, I position the project within the NCD prevention and care cascade and put the different aspects such as community and facility education, screening, community and facility screening, and things like referral and linkage all through the process, and the outcomes that I'm interested to see. Here is just the referral and service pathways in the project. And then, of course, we need a comparator for the model, and the comparator is the standard of care or usual care, how things are now without integration. And this was done in conjunction with the key stakeholders, as I indicated that at the start we held a workshop and sort of to get the local perceptions on how things go. So this is basically the patient flow at primary health care and the high-level facilities, because this model had an aspect of referring patients from the community to the facility, but also from the facilities, the primary care facility to high-level facility to manage complications. And then another aspect of understanding the problem is understanding the natural history of disease. A decision analytic model to be built, you need to understand the progression of diseases of interest. In this case, we are looking at hypertension and diabetes, and therefore, because my interest is comorbidity, I needed to sort of understand for a patient with hypertension and or diabetes, what is the natural progression, and those will be used to attach parameters of impact in the model. And so the stages were findings from a systematic literature review, which was the first stage of my PhD. So I looked at how decision analytic models have been used for integrated care globally. And then for those that were done in Africa, which were only 2, I sort of tried to see how I can infer the natural history. But then stakeholders in the second stage also gave feedback. And then the final stage in the understanding the problem is in intervention mechanisms of impact. It's important to know how are you going to conceptualize how the intervention leads to the intended impact. And so this is a very iterative process, speaking to key stakeholders, including the program team, as well as key stakeholders in government, academia, and research. So basically, I had to look at what happens when you're not in care, and as a result of the intervention, which is known as Peak4C, sorry, I didn't mention it before, what happens when you're in care. So, of course, a person has his own characteristics, and based on that characteristics, they bear risk. And when you enter into an intervention clinic, which is an integrated clinic, evidence shows that, and also from data analysis, that entry into care increases the number of people who enter the facilities, and retention is also better than how things are. And those are how I'm going to infer the risk. And therefore, there will be less CVD risk compared to someone who is not in the integrated care clinic. And so that's how I'm going to postulate that, to assess that. And then after understanding the problem, which has involved all those different steps, you now develop and justify your model structure. So you need to know what type of decision analytic models you're going to use. And of course, it comes from the understanding of the problem, as well as results from the systematic review and stakeholder engagement. So we are lucky that research has been done, and the existing taxonomies of choosing a model that you're going to build. So this is from Professor Brennan and colleagues at University of Sheffield, as well as, and it was updated by Professor Andrew Briggs. And from the evidence I found here, we decided to use an individual sampling model, which sometimes is called a micro-simulation model. So this is an individual patient model because, for example, common cohort models have limitations. For example, lack of patient-level heterogeneity, whereby you have a patient with hypertension, you have a patient with diabetes, you have a patient with both. How will you make sure you're taking care of the different parameters, the individual heterogeneity in the population? The memoryless assumption, because sometimes you'll have people who have already have a history of seeking care, and you want that to be incorporated in the model. Some people already have previous diagnosis, you have to incorporate that history. But if you're going to do things like cohort models, you're not able to do that. So then the last step is developing and justifying the model structure. And in this, you basically need to understand and incorporate the evidence. And here it is just identifying where the parameters for the modeling will come from. A lot of work so far has gone into this, and there's still a bit to finalize, but basically the data sources include the project data sets and then nationally representative data sets, because you'll have prevalence of hypertension, prevalence of diabetes, prevalence of comorbidity in Kenya. And then published literature, because published literature could also give you different aspects such as, how outcomes change due to drug availability, considering one of my key things is that if you're in the integrated care models, in the integrated care clinic, then there is less stock out and you're less likely to default on your drugs. So such kind of evidence I'll have to do literature searches for. And yeah, of course, I've talked about quantitative data analysis that I did with the intervention data, as well as what they've already published, which I will use as well. So in conclusion, conceptual modeling is quite a key process, and it needs to be reported as part of transparency in public health decision analytic modeling. And this is something that I think we need in our setting, especially for interventions that are just coming up and limited evidence exists, such as integrated care. And in my project, it was very useful in identifying the model type, aligning my work to the decision-making context, and making sure that the model that I build will resonate with our local challenges in terms of chronic disease management. And then it also helped to identify what parameters and where I'm going to get them from. And then stakeholder engagement, I cannot stress this enough. It was very useful. I think I spent a lot of time doing stakeholder engagement, and it has its own challenges. Sometimes can be frustrating, but then I am glad that I did it, because I'm seeing the fruits of that now. And then it's challenging to identify mechanisms of impact of integrated care. So integrated care is a very complex intervention. There were limitations of the data that I could get. The intervention has been implemented only on one part of Kenya. I have to make assumptions or scenarios for the whole country, but then there is a lot of gaps and a lot of further exploration that can be done in terms of integrated care as an intervention. So that is what I learned. So I want to thank my supervisors, welcome for the funding, collaborators, colleagues at Sheffield University and at SHA, where our department is based. My colleagues are also in the room. And yeah, you all for your attention. Thank you.
Yeah. Please remember to note your comments. Elvis, you are over supervised. So we expect very good work. 3 supervisors. They're all powerful people, I know them, and 5 collaborators, including my friend Edwin Barasa. Okay, so the second presentation will come from Dr. Pamela. She's a research fellow with the Health Policy Research Group, which is the largest health policy research group in Africa. I'm aware that they are here with 15 presentations. Pamela is a lecturer at the Department of Psychology in the State University of Science and Technology, Enugu, and she holds a PhD in industrial/organizational psychology. Her research interest focuses on health systems corruption, governance and accountability, and urban health, as well as community and public health, and occupational health psychology. So, Pamela, over to you. You have 10 minutes.
Good afternoon, everyone. Thank you so much for this opportunity. So I'll be speaking on rethinking accountability mechanisms as anti-corruption strategy in primary healthcare centers in Nigeria. Okay. Corruption and rent-seeking activities has been so prevalent in Nigerian health system across all the levels of health system, federal, state, and at primary level. But our research focuses on primary level healthcare because primary health centers is the first contact for health services and it's easily accessible for people. So following our previous work, we found a lot of corrupt practices and health system inefficiencies that goes on in primary health centers, ranging from absenteeism, informal payments, procurement, corruption, use of volunteer health workers as cover-up for absenteeism. And this has been so prevalent, and this continues to happen in these health facilities. Although there have been some accountability mechanisms in place, okay, that's been in combination of the formal and informal structures, but corruption still persists in our primary health centers. So what could be the reason that this is still persisting? So this brings us to this study. That's why we are so interested to find out what is currently happening in these primary health centers and what can be done, okay, to reduce corruption in our health, in our primary health centers. So we conducted a study using a qualitative study used in Enugu. We selected 4 local governments, 6 primary health centers, and local government headquarters, health departments in Enugu State. So we used a qualitative study to examine the accountability mechanisms in place in our primary health centers. So we use ethnography, participant observation, and also in-depth interviews for this. The analysis was done using NVivo 12. Then the conceptual framework for this study, we used the Brekerhoff 2003 accountability framework. Okay, we start with mapping out the different actors in the primary health centers, both the formal and informal actors, and now look at how do they interact in providing accountability or providing some support in these health facilities, and also looked at the 3 types of accountability: financial accountability, performance, and the demographic accountability. So coming to the results, so first of all, the mapping, shows the formal and informal actors at the different levels of healthcare in Nigeria. So at the federal level, we have at the state and the local government. Then the PSC is being found in the local government, that's the communities. So down here, the 3 of them, okay, work hand in hand in providing support to the PSC. Then down we have the partners, okay, then They also provide support to the primary health centers, then the communities too. Yeah, the traditional leaders, the World Development Committee, and some members of the community, then down to the world level. So the ones that have the take arrow show the former actors, while the ones that have the disjointed arrows shows the informal actors. Of course, we also have the CSOs and also the service users. Then coming to the relationship that these actors have in this in the primary health center. So you can see here that we have a lot of things that are going on here. Okay, and they have different types of relationship, starting from the formal and informal actors. And sometimes some of these activities, conflict with each other, and that's what affects the accountability mechanism in primary health centers. So we have the funding, they get funding from different sources, then the oversight and governance, okay, from the State Primary Health Care Development Agency only, and also the local government supervision. So they have multiple people that supervises them from the state, local government, and community. Then when it comes to reporting, okay, so the PACs, they mostly report to multiple sources. Then security, capacity building, infrastructure development, payment of salaries, and supply of medical and equipment and drugs. So some of these relationships are conflicting, that they have to give feedback to different sources, and this affects promoting strong accountability system in our PSCs. Okay. Looking at the framework, the Brinckerhoff framework. So he mentioned 3 types of accountability, which we use to assess our PSC. So for the financial accountability, of course, there are funds. So the funds comes from the basic healthcare provision fund comes from the federal straight to the health facilities, while they also get some funding from the local government. Then in our PACs, we found out that there are paper documentation, okay, and these health facility managers do report to different actors, upward and downward, and there is also co-signatory of the funds, okay, used by the facility, by the officer in charge, that the facility manager and the community leader, World Development Committee chairman. Then the gaps that we identified is that these health workers are not really involved, okay, when planning for the budget preparation and disbursements. They're not really involved, so their interests are not really captured so well. And for the there is also strict adherence to the laws about the flow of funds coming from the state, from the federal, state, local government to these health facilities. And the facilities also use manual system to report these financial spendings in the facility. Then for the performance accountability, so this looks at, of course, this looks at procurement of drug through a particular system. Okay, so we call it the DFIR in Nigeria, but sometimes one of the key challenges that they have on with this system is that the drugs are not usually available all the time. So there are some cases of stock out, and these health workers will now resort to buy drugs by themselves from private shops and all that. And by that process, they can actually make some profits, additional money, okay, to ensure that they keep this facility working. So the gaps there, we look at, there is no clear procedure, okay, for their appraisal, for the performance. And I've mentioned before about these drugs are not regularly coming all the time. Then the political accountability, So this talks about the provision of health services and treatment of minor ailments for service users. So this health facility, of course, this happens very well, and they are there to provide these services, although there are some cases of absenteeism that we experience there. Then response to service users' needs and increase on users' trust. But the main gap that we encounter there is that the complaint mechanism or the feedback mechanism is not really strong. So when these users experience some difficulties or some corrupt practices and all that, there is no like a clear channel, okay, for them to actually report what is going on in these health facilities and also get feedback on the way forward. So why is accountability mechanism seems not to control corruption in our PACs? So first is that there is conflict of interest among the multiple actors. Like we've seen that we have a lot of multiple actors from formal and informal, and of course, political interferences, okay, because most of these actors want, have their own interest, okay, and they want their own needs to be met, okay, so there's a kind of conflict, you know, and people try to push their power, okay, to make sure that their own interest is being protected. Then I've talked about the complaint mechanism that is not so efficient. Then there is weak enforcement of rules. So there are rules in place in our PSCs. These rules are there already, but enforcement of this rule becomes a problem. Okay, so the rules, some of these health workers or health facility managers, there seems to be like above the rule. Okay, these rules are there, but do they strictly implement these rules to ensure that they promote accountability in our PACs? That answer is no. So these rules works for some people, why it does not work for some people, because some have some political power and all that, so they seems not to be able to enforce these rules. Then there is no synergy between the formal actors and non-formal actors. So people, some of them seems to act on their own. Okay, so they seem to act on their own. They have their own objectives to protect. So they want to be sure that these facility managers, okay, produce their own result, their own output or their outcome. Okay, neglecting those other ones. Okay, then there's also the resources. Okay, like drugs, medical supply and equipment, they don't always come as when due. Okay, so this also gives room for corruption to prevail in these facilities. So they supply them, but sometimes they experience some kind of stock out. And when this happens, the health facility managers, you know, and other health workers, you know, use this opportunity to procure theirs and resell and make extra profit. So what can we do, okay, to improve accountability in PACs? Okay, so there is important that the PACs in Nigeria implement the public financial management framework, okay, ensuring that there is strict adherence to financial laws. There's also need for the formal and informal actors, okay, to work hand in hand. Okay, this involves, you know, multi-sectoral approach. Those are the government, the community, individuals, CSO, media, everybody needs to come hand in hand to ensure that they uphold the accountability mechanism in our PSCs. Then improve the complaint or feedback mechanism for the service users. They should know their rights. Okay, so there is need for sensitization in communities to ensure that they know what they expect to get from this PACs, okay, that this is their right, and the PACs is also theirs, is their own, not government. So they are the government. So there is need, okay, for them to be aware of their privileges and their rights in these PACs, and those and also to know the free services and the ones that are not free, and have a proper channel, okay, to report when they notice that there are some type of irregularities in these health facilities. Okay, so I will leave you with this, and then as I conclude, in conclusion, there is need. Okay, there is need for our PSCs to, there is need for Nigerian PSCs, okay, to work hand in hand, that's the formal and the informal structures and actors, okay, to work hand in hand to improve accountability mechanisms in Nigerian PSCs, although it's there already, but there are some problems, okay, that is making these mechanisms not to work. So we need to go back again to look at it, to think very well, what can we do to improve? And I believe that implementing some of these, okay, that we found will help to improve accountability mechanisms in our PSCs. Thank you so much.
Okay, so thank you very much, and for that wonderful presentation. Please, we are reminded to write down our comments, questions, and all that. So the next presentation is going to come from the Emily Group. Huh? Are you there now? Okay. So please come up. They will be making a presentation on the implementation cost analysis of a COVID-19 test and treat program. The real world evidence in 3 countries, Ghana, Malawi, and Zambia. You got 10 minutes.
Good afternoon. My name is Mwava Mlenga. I'll be presenting on behalf of the team. Emily could not be here, so I'll be the one taking you through the presentation. That's my outline for the presentation. Then about the COVID-19 Quick Start Consortium. So this was a catalytic private-public partnership with 10 ministries of health across Africa and Asia. The aim was to rapidly introduce COVID-19 antivirals in low and middle income countries and be able to support these countries to set up and build capabilities in responding to COVID-19. The objectives for our study, I think the main objective was to rapidly introduce the COVID-19 test and treat program. And as I mentioned, we also wanted to support these countries to be able to prepare for and finance future pandemics that may be affecting low and middle income countries. And for specific objectives for this work, we wanted to identify what the startup and operation costs would be for the COVID-19 test and treat program, and then to develop different scenarios to estimate the cost of operating the COVID-19 test and treat program under different conditions. So in terms of methodology, our study settings as introduced were in 4 countries, Ghana, Malawi, and Zambia. And in terms of number of facilities that were involved in this study, for Malawi and Ghana, we had 4 facilities. And for Zambia, we had 9 facilities that were included in this data analysis. For the level of facilities that were involved, both Malawi and Ghana had level 2 and level 3. For Zambia, they had healthcare centers, level 1, 2, and 3 hospitals, as well as 1 specialized military hospital. For the period for which this data was collected, you'll see that there's a difference in terms of period. This is dependent on when the program was set up. Zambia's data was collected between 2022 December to 2023 December, whereas for Malawi, it was between July 2023 to March 2024, and Ghana was May 2023 to May 2024, but covered a period of 12 months. For the number of tests that were conducted, Zambia had the highest, just over 17,000 tests that were conducted, resulting in 1,600 positives, as well as 392 of those that were treated with COVID and antivirals. For the steps that we took during this cost analysis, the first one was to estimate the setup cost. That was a startup cost for the COVID-19 test and treat, and what were the inputs. Then from there, we went on to estimate the monthly operating cost. So to be able to arrive at a monthly operating cost, we looked at recurrent costs for this program, and these were converted into a monthly cost. Step 3, we estimated all-in cost for the test, each test that was conducted, then all-in or cost for each treatment that was delivered. Then we went on also to do some sensitivity analysis, what factors would lead to an increase in the operation cost. Then step 5 was also to model different scenarios. The key components in terms of costs were divided into one, like I mentioned, what the startup cost, as well as the operating cost. In terms of inputs for the operating costs, were direct and indirect costs. For the indirect costs, it was mainly, we looked at utilities that the facility was incurring. And then in terms of the direct costs, we had looked at the supplies, which included the drug, as well as the test kits. Then we had personnel cost, supply chain costs, and routine program costs. For the startup costs, we had looked at trainings, workshops, and what it took to be able to activate a facility. Just to take you through the findings, the first step, we'll look at the startup and operating cost. So this is just a summary of the startup cost and the operating cost. So for startup cost, Zambia and Malawi had similar startup costs, just above $6,000 to be able to set up a facility for the COVID test and treat. Then Ghana had the lowest costs at $2,983. And this mainly was because as we were setting up the COVID-19 test and treat program, we were using the systems that were already in place. So depending on how many trained healthcare personnel they had at that facility, and the level of healthcare personnel, trainings that were designed by individual facilities as well as programs were different. Others did mentorship because they had personnel that already were qualified in terms of management of COVID-19. For the average monthly operating cost, you see that Zambia had the highest monthly operating cost at $8,738. Some of the reasons behind this cost included just the number of tests that Zambia conducted, as well as some of the indirect costs that were associated with running a facility. And some of these indirect costs included higher utility expenses that were observed in Zambia across the facilities. Then for the average all-in cost per test, Zambia had the highest at $55 for you to be able to conduct that test. And this included the personnel that was conducting that test, as well as the cost of a test. For you to deliver a treatment, again, Zambia had the highest cost at $3,433. And again, the level of cadre that was involved in delivering that cost really drove the all-in cost for treatment. Just getting into a little bit more detail per country and the percentage splits for how the costs were split. So we did notice from our analysis that personnel was the highest driver of cost across the 3 countries. If you look at for Ghana, we had 63%, which was the highest in terms of personnel cost. This was closely followed by Zambia at 50%, and then for Malawi at 41%. Ghana did not report on the indirect costs simply because of the way their system is set up and how that cost is incurred by the facilities. So This one was just sensitivity analysis, trying to see if we had a change in price of, for example, the test kits or the drugs, how much would this influence the operation cost? So we took either a 5% or 10% increase in terms of sensitivity. What we saw was that this led to 1% or less in terms of operating costs. It didn't have a significant impact on that monthly operating cost if the change in terms of these prices for either the drug or the test kits. Scenario number 2 was to then model the COVID-19 scenarios. The first model we're looking at SAGE modeling. So we took the highest number of cases that were reported, the highest positivity per month that the facilities had reported, and then modeled that to give us the worst case scenario that you'd get. And then for the second scenario, we had looked at task shifting. If facilities were to use the lowest allowed cadre to be able to perform tasks, what would be the cost, the operation cost for COVID-19 test and treat program? So these were some of the findings. If you look at the first line there, that's the main analysis. In Ghana, if you look at our average monthly operating cost, the main analysis did show that it would be 901. If you are dealing with a SAGE, an increase or threefold increase in terms of number of cases, the cost does jump up to 2,955. And in an event where you are task shifting, you see that there's a saving from 901 from main analysis to 784. We see similar trends for Malawi as well as for Zambia. So under the SAGE conditions, what are some of these, what were the drivers of costs? So again, we see that for cost drivers were mainly the same under the SAGE modeling, where we are seeing an increase in terms of number of cases. Really, personnel cost was the main driver. As you can see from Zambia, the cost jumps from 50% to 88% in terms of personnel cost if we saw a SAGE in terms of number of cases. Because it's really the personnel that you're shifting around. This was the main influence in terms of the lower costs that we saw if you task shift, that is using lower cadres. And there we see, for example, for Ghana, from 63% in terms of personnel, this reduces to 57%. From 41% to 14%. What are some of the conclusion as well as key policy implications? As I mentioned, we were using this work to also inform governments in terms of preparing for other pandemics. In terms of supplies as well as antivirus, we see that the cost remains relatively stable, even where we see an increase in terms of price by 5 or 10% increase. Personnel cost remains the biggest driver of cost. So really task shifting is something that can support national governments to really save when it comes to responding to pandemics. SAGE, where we have a SAGE in terms of number of cases, we know we may need to really invest in supply chain as well as a plan for higher test kits. So establishing test and treatment program require initial investments. I think this has been established, but once you make that initial investment, I think operating costs really does go down. And because of the way this system was set up, where we are really using what national governments had already put in place, we are simply just showing that it really is possible for you to be able to set up and rapidly introduce new treatments and a new program in such a manner. So the infrastructure that was created presents an opportunity for us to support long-term health initiatives and be able to justify the initial high startup cost. then operating the program can be cost effective if we were to use a task shifting model. That's my slide.
Thank you very much for that wonderful presentation. And so finally, we get to Keziah. She's from the Ghana College of Physicians and Surgeons, and she's working on Stop NCD in Ghana, Burkina Faso, and Niger. But she's going to be presenting their findings in Ghana. So Keziah, over to you. She'll be presenting on factors influencing access, quality, and utilization of PHC for patients living with hypertension in the West African region. Okay, sorry, so she's presenting their findings in the 3 countries.
Thank you very much. It's a privilege to be able to share my findings with the group. As Prof mentioned, I am part of a study called Stop NCD, which is looking at non-communicable diseases in the West African region. Sorry, previous slide. Just to acknowledge our funders, the NIHR, UKAID, and we are working, as Prof said, with Ghana, Niger, and Burkina Faso. So hypertension, as we all know, is a very prevalent non-communicable disease in the West African context. Currently, almost 3 in every 10 adult West African person has hypertension, and that's a very serious problem. And the good thing, however, is that hypertension is very primary care sensitive, which means that if you have very good primary care, you are likely to be able to live a very good, somewhat regular life. So the aim of our study was to assess the factors that influence access, utilization, and the quality of primary care available to patients with hypertension in West Africa. So we looked at these factors in 3 categories: at the context level, the health facility, health system level, and the individual patient level. And we also identified gaps in the research where further research is required for primary healthcare in West Africa. Okay, so based on our literature review, we were able to adapt a conceptual framework which looked at the 3 areas that I mentioned: macro, meso, and micro level, and how they influence primary care for patients with hypertension. So we conducted a scoping review as described by Askey and O'Malley. We looked at published literature in the databases mentioned above: PubMed, Embase, Scopus, Kane Info, and Google Scholar, between the periods of January 2000 and December 2023. So we included reviews, observational studies, and reports which focused on patients with hypertension, adult patients, and studies that were conducted at the primary care level. We looked at studies in English, French, and Portuguese, and we didn't include any studies on gestational hypertension or preeclampsia, as we're only looking at essential hypertension. So we extracted our data onto an Excel sheet and we analyzed it thematically based on the components of our research question. So this is a Prisma chart, which is a requirement for doing a scoping review. It shows you how we came about the studies we included in our review. And as you can see here, we started with a large number of studies from the searches of the various databases, over 5,000 studies. But based on our screening, using our titles and abstracts, as well as full paper extraction and our inclusion and exclusion criteria, we ended up with 16 key studies that we included in our review. So for our findings, at the contextual level, one key facilitator that came up in several studies was the availability of policies and how they were implemented. For example, the National Health Insurance Policy was found to be a very key factor for many patients in being able to access primary care facilities for hypertension. However, there were several barriers. Some of them included policy limitations on medication prescribing. So only certain healthcare professionals were allowed to prescribe antihypertensive medications or even diagnose patients with hypertension. And so patients who go to healthcare facilities that are at the lower levels are not likely to meet that cadre of healthcare worker, and so they won't have access to such services. There was also poor prioritization of non-communicable diseases in government funding, and this was key because there were several policies regarding hypertension and non-communicable diseases in general. However, the policies were there, but funds were not properly allocated to them. Because I think in our region, we struggle with communicable diseases as well. And so the burden is double, if not even triple. And transportation, in terms of bad road networks, far distance of healthcare facilities from patients was also a key factor mentioned in some studies as a barrier to accessing and using primary care facilities for hypertension. And socioeconomic barriers were also reported to affect availability and affordability of medications. At the health system level, again, we see health insurance because it came up again as a key factor that allowed patients to have access to hypertension care. So, for example, studies in Ghana, where Ghana has a national health insurance scheme, where the antihypertensive medications are given for free or are supposed to be given for free for patients under the scheme. It showed that there was a vast improvement in access and use of primary care facilities because of this health insurance. However, some of the barriers included inadequate healthcare personnel in terms of capacity and quantity to manage hypertension. And there was also a skew in the data for health workforce distribution, such that people in more urban areas had access to better, higher skilled health workers than those in the rural areas. There was also lack of equipment and supplies and medicines at the primary healthcare facility. And health financing was an issue in many countries, especially where there was no health insurance system in place. And also service delivery was an aspect that came up as a barrier. There are several service availability studies that were done in Nigeria, which showed that healthcare facilities at the primary care level were not adequately equipped to manage hypertension. Finally, at the patient's level, we found that an important key factor that enabled patients to use and access primary health care for hypertension was having knowledge about hypertension and being able to have access to counselors to tell them about their condition and how to properly take care of themselves. Also, communities where patients had very good support from their household, they showed higher rates of hypertension control and better medication adherence as well. Some barriers that came up were financial challenges, as I mentioned earlier, and also some poor health-seeking behaviors. So we found that some patients preferred to go to alternative healthcare practitioners rather than to go to the primary care facility. There were also issues of medication adherence as well at the individual level. So there are several gaps that we noticed from our review. We noticed that most of our studies were from Ghana and Nigeria. So I mentioned that we included 16 key papers, and it's amazing to note that 10 out of the 16 were from Nigeria and 4 were from Ghana. And this is a problem because we know that in the West African region, out of the 16 countries in West Africa, 9 of them are Francophone speaking countries. However, the papers that were readily available were mostly Anglophones from Anglophone speaking countries. And so we are not getting the data from the Francophone speaking countries. And this may make our findings hard to generalize to the entire West African region. We also noticed that there were not many studies that explored the reasons for the implementation gaps of the hypertension policies at the primary care level. And that's very important to be able to understand why the policy is there, but it's not being well implemented. And we didn't find many studies that explored governance and leadership and health information systems, which are key building blocks of the WHO health system building blocks. And they influence how patients are able to access care. And so we believe that studies we need to conduct more research into these areas and how they are affecting patients' access to primary care. We also didn't find any studies that explored the effects of situational factors like war, Ebola, COVID-19 on patients' use and utilization and access to primary care for hypertension. We think that this is also a very important area of research that has a gap. So as I showed you a similar image in the beginning, our framework from our literature, we found that most of the factors we found from our scoping review were in line with what the literature was saying. However, we think that one thing that was missed in the literature was how interconnected these factors are. So it's not enough to have interventions placed at one section of the health system and ignore the other sections, thinking that that would solve the problem of primary care access. For example, if you take the national health insurance I mentioned, there could be a policy in place that has been put at the macro level. But if there isn't funds allocated for that policy to be implemented, you come to the health system level and the insurance is there, but the patients are not benefiting from it. And the patients are paying out of pocket, leading to challenges at the micro level. So these factors relate to each other. So finally, we think that based on our review, that if there are going to be interventions put in place to help mitigate some of these barriers, it's important that these interventions are synergized and targeted across all the levels of care. It's not enough to put just one intervention at one side. It will end up just being redundant. It's better to work together with all the various aspects of the health system. Also, governments need to prioritize NCD care. We know that currently our region suffers from communicable diseases as well as non-communicable diseases. And although we are in a difficult situation, it's not enough to ignore non-communicable diseases because they are slowly becoming a very huge problem in our context. Policymakers should also be sensitized to the benefits of a national health insurance. Clearly, our studies showed that in the countries where they had health insurance, patients had better access and utilization of primary health care for hypertension. And this is something that we should all strive to achieve, universal health coverage for all patients with hypertension. And interventions should also be targeted at improving health worker knowledge, exploring tax shifting opportunities, as my co-presenters mentioned, and enhancing availability of antihypertensive medications at the primary care level. And it's also important to not ignore patients and household education, as empowering patients leads them to making better choices about their primary health care. Thank you very much. The study has been published in BMJ Open. It's open access, and I've put the links here for anyone interested to read more about what we did. Thank you very much.
Yes, thank you very much for that presentation. And it's good to learn that it's also has been published. So over the last 1 hour or so, we have gone through 4 presentations. So can I call up the presenters to come up here for a quick response to very, very important interventions from the listeners. And just as a reminder, the first, please come up to the height. This is the only evidence that you presented. So please sit, yeah. We started with Elvis, who dealt on modeling in multimorbidity, you know. And he said there was need for evidence. And then went through the steps in modeling. And in those steps, he highlighted the key issues that are needed for modeling. The need to involve key stakeholders in modeling. The need to understand the problem, including the natural history of the disease and intervention mechanisms and their impact. And then again, to identify the model structure, whether it's going to be an individual model and so on and so forth. Then the second presentation was rethinking accountability mechanisms as a means of strengthening governance in primary healthcare centers in Nigeria by Adobe. She looked at the types of financial accountability. I mean, types of accountability, including financial performance accountability, political issues, and the fact that we need several actors interlinked at the national, subnational, and local levels. And these interlinkages causes a lot of problems, a lot of conflicting relationships, both from the formal and informal health system. She highlighted several issues and gaps, including financial, political, and other issues. And then zeroed in on why accountability mechanisms have failed to control corruption in primary healthcare. And this included conflict of interest, political interference, supervision issues, unclear rules and regulations. And then, of course, she made recommendations on how to resolve some of these issues if we don't want to see accountability again in the primary healthcare setting. The next presenter, which is Mwaba. Mwaba dealt with the implementation cost analysis of COVID-19 test and treat program, and then the real world evidence in Ghana, Malawi, and Zambia. He took us through steps in cost analysis and the need that you need to do it at different facility levels. Then we went through the startup costs and operating costs. And then the results showed various averages in costs, both for in-cost per diagnosis and per treatment. And then told us that the key driver of cost here is the personnel cost, especially in Malawi and Zambia. And then, of course, in the results, there were different cost drivers for different countries. Task shifting model issues were also raised, and that some of these interventions tend to be more cost effective if you're using the task shifting. And finally, Kezia, went through the factors influencing access, quality, and utilization of primary health care for patients living with HIV in West Africa. So they did a scoping review. So she went through the methodology for this scoping reviews and x-rayed the facilitators and barriers to utilization. And this, for the facilitators, this included policies regarding access to care, availability of their national health insurance, which provides financial backing, and then some barriers like policy limitations, socioeconomic barriers, inadequate human resources, poor funding. And then she also x-rayed gaps in research, which includes non-availability of data, especially from the Francophones. And she concluded that there's need for integration of interventions, especially at different levels. So these are just briefly what they told us today. So the floor is now open for questions, or if you want more elaboration. No, if you want elaboration, you will meet them outside. So questions? Yes, one. Any other person? No, wait, not yet. Any other person? Two? Number two, yes, you will comment. Number two. Any other person? Going? Going, gone. So we have two interventions. Please tell us your name. Tell us who you are addressing the comments or the questions to. So number one, yeah.
Thank you very much. Robinson Ayando from Cambry Wellcome Trust in Kenya. I have a question for the last presenter, Kezia. I just wanted you to perhaps reflect. I think you've highlighted to us some of the gaps for future research. And my understanding of the work you've presented is on access, enablers and barriers at various health systems levels. And of course, as we acknowledge that health systems are complex adaptive systems, and to that, what that basically means is that the hardware components, the things to do with infrastructure, financing, equipment, and what have you. Then we have the other software components that will also influence access, especially at the micro level. So I'm just wondering your reflection around, also doing research or recommending that research that takes into account the complex adaptive nature of health systems, if that's something that perhaps you could recommend given your research findings. And the other question is...
there was a workshop we went to and they asked somebody a question. And the person in response, he said, when she remembered the answer, she forgot the question. So can you make it brief so that we don't forget the question? Yes.
All right. So my question is really, given the scoping review that you conducted, would you recommend that there's also perhaps value in future studies to also conduct research that will take into account the complex adaptive nature of health systems and how that might influence access? Yeah, I think I'll ask that for now.
Okay, thank you. Thank you very much for the question. And I think it's a very excellent point. I agree. I think the health systems are a very complex area of science. And it's not as simple as, even though I have drawn it in 3 circles to make it seem, 3 sections of health systems, you note that one section was actually called health system. And so that should tell you how complex health systems are. We try to define it in areas, small segments, to make it easier for us to allocate certain things to certain places. But truly, I agree very much that there's a lot in the health system and the way it functions that influences how patients are able to access care. So I think it's kind of linked to my point about the interconnectedness of the 3 areas of the health system, such that you cannot just look at one side. Each side affects the other side. How the patients are able to access a care is influenced by how much they're able to afford the care, whether the drug is available at the health center or the primary healthcare unit they go to. And so I think, I agree with you that it's an area that definitely requires more research. Yeah.
Thank you very much. First of all, I want to appreciate all the presenters for the nice presentation. Mine is not a question, as I've said before. I'm just directed to Adobia from Nigeria. You did a very wonderful presentation. And from your finding, this comes very clearly that inconsistent and deficient supplies of resource in medical supply at the facility level is becoming an alarming thing. So I'm just very curious to understand, what would be the procurement system in Nigeria, maybe from where drugs are procured until to the last mile delivery. Maybe the blockage happen in between, or is it issue to do with funding? Maybe you can just clarify a bit on that.
Okay, that is not a comment now. In fact, that's a very strong question. So over to you.
Okay, thank you for that question. Okay, so the problem with the procurement process is not just the funding. Okay, so the funds are there already, and the major problem is the actors. Like the procurement process, we have the different actors, that goes on, starting from those that will have to make that request. okay, then approval of the request, then the storekeeping, that's procurement now takes place, then in fact the bidding takes place first, then the procurement, and then movement of those supplies to these health facilities, okay? So the funds are there already to provide, to procure these items, okay? But sometimes, most times is the systematic problem, those actors, those processes. So we have different actors, that play different roles in these processes. Likewise, and among these actors, there are some corrupt practices that goes on there at each level. So these are the main problems that affects these processes. Sometimes too, they procure some items that these facilities do not really need, or they still have in store. Okay, and this makes the other one now be out of stock. Okay, so when you now have a particular much large number of items that these facilities do not really need, that means that the other one that these facilities need will not be there. And this forces the health workers now to find a way, okay, to procure these items to ensure that they have it for the service users. Thank you.
Yeah, thank you very much. I want to assume that there are no more interventions. So I would like to thank all the listeners and all those who have asked questions and all those who have kept their questions to themselves. So thank you very much. I'm not surprised that you didn't ask the two gentlemen questions here. One worked on cost effectiveness analysis, the other one worked on modeling. And these two areas are very stochastic. So people don't want to go into it. So thank you very much, presenters, for that wonderful presentations which you made. So on this note, we are going to close this session. But before we close these sessions, please step forward for photograph. We have two rapporteurs. The first was the official one. When I didn't see the official one, I had to conscript the unofficial one. So can two of you step forward for a group photograph? Thank you very much. So all the photographers, both formal and informal, both those who are going to be paid and